Thomas.
Gordon.
Professor Thomas Tursz, Institut Gustave-Roussy in Paris. You are a very experienced and senior oncologist and Institute director, and you know the bottlenecks in the process of personalized medicine. We're a little bit glib about the idea of translational medicine, personalized medicine, but it's not so easy. You have three bottlenecks to describe for us. The first one's about clinical trials.
I think there are very important issues because really targeted medicine and in personalized medicine is the way we are going, we want it or not. It's the way progress and is going, it's the way patients will claim for. And we have to adaptate our own organization and our hospitals and our own networks to this new reality. Clinical research, clinical trials are becoming so important and mandatory, not only for investigators, not only for pharmas, but for patients themselves, because with this targeted drug, they can have unique opportunities to get the right drug for their own tumor. So it's important that more than 3 or 4% of European patients who actually have now access to clinical trials will ask for clinical trials and will be aware of running clinical trials in the various European institutes.
So 97% of patients with cancer in Europe are not in a clinical trial?
Are not in a clinical trial, are not in a strategic trial, and to some extent are cut from innovation. And so it's not only the process of getting a new drug, it's also entering all the complicated investigation, genetic, genomic investigation, radiologic investigation, which are needed for this investigation of drugs. And this will be very important for the patients to claim for them, for their own interest and for their own benefit.
Sure, because there is evidence that patients in clinical trials do better than those who are not. So 3% of our population are getting an advantage over the 97% who are not.
But with targeted drugs, it will be more than that, because you have a chance that you can have a unique drug which is targeting your own mutation of your own individual tumor. And it's not only that it can improve your life from a few weeks or months, it can really lead to some complete responses and advantages which can be measured with years. And this is indeed a change in the way we are thinking of oncology. It will be a small subset of patients, but their interest will be to find the right trial with the right drug for their own tumor.
Sure. Now, do you expect a blockbuster drug, a cure coming down the line?
No. I'm not, with a strange exception of a Glivec, with a chronic granulocytic leukemia, imatinib and GIST, but which maybe are specific case of cancer. In one I think all the results we have now are showing that yes, we have indeed extraordinary and spectacular responses in some patients with some complete responses. And the best example are melanomas, in which no drug, more or less, was active in the last 50 years. And with now 2 drugs, we have spectacular responses. And with one of them, the inhibitor of BRAF, which is a mutation occurring in 50% of melanomas, with this inhibitor, most of the patients, if not all the patients, are responding, even with a large burden of metastasis, which is spectacular. But most of these patients are also relapsing. There is an advantage in survival, which is something. And we have really a regression of a number of metastases that we never saw before. So this is a new thing. But the fact that patients are relapsing is showing that this is indeed a Darwinian process. There will be new mutations and resistance mechanism, exactly as it is occurring with antibiotics. And now the concept of associating antibiotics to avoid this resistance is basic medicine. It will become the same with this new targeted drug, and the future will be combinations of targeted drug in order to prevent or to prevent those resistance occurring by new mutations.
But we're not doing combination trials.
We are not. It's very difficult to do it at the moment because with pharmas and also clinical investigators are still stuck with the old phase 1, phase 2, phase 3 model, which is maybe not so accurate to test so many new drugs in a short period of time. And the policy of pharma is willing their drug to enter the market, which can take 10 years. And if combinations are only allowed when one individual drug enters the market in one indication and can be used in combination with other drugs, we are wasting a lot of time, a lot of money, and a lot of hope for the patients. But pharmas should also think that they have a lot of complicated issues to solve themselves. And the main is their atrial rate. From 100 drugs entering phase 1 trials, only 10%, only one drug out of 10 will become a real drug entering the market. So they are losing 9 drugs out of 10 for which they already spent preclinical and money for experimental development. I think European, with the network and what we are doing, can offer a platform for pharmas which could be very interesting as a rescue mechanism for all these, let's say, second-class drugs, which will never be developed as a unique drug to enter the market, but could be rescued and reveals to be quite interesting if they are used upfront in combinations.
With existing drugs.
With other targeted drugs, targeting the same biological pathways or different pathways in the cells. And we've shown already in many models that targeting the same pathway at several levels or targeting 2 or 3 different pathways in the cell is much more efficient than targeting only one target. But the major problem is the policy of companies which do not want to favor their competitors by allowing investigators to combine drugs with another investigators, which is a major mistake, because their interest would be to rescue their drug, even if it is combined and associated with a drug from one competitor. And I think this idea of asking upfront combination trials with drugs coming from different companies cannot be done everywhere, but can be offered as a service and a new type of relationships between academia and pharmas in the frame of European.
And then the other thing that's missing in the puzzle is using these new drugs in combination with existing treatments like radiation therapy.
This is very important. This is very important.
And pharma also don't do that.
They don't do that.
Nor do we.
They don't do that. They don't associate new drugs with old drugs, which could be very interesting. And what you are saying about combination therapy, which is acting on more or less on the same targets, and which is also a kind of targeted therapy, could be extremely useful and interesting, and could lead to new discovery and to lead to major benefits for individual patients.
Now, Thomas, the other bottleneck which you were describing at the European platform meeting was biobanking. And there's a big work package on biobanking, and everybody's trying to put their heads to how to do this properly, how to make the use of the network, and so on.
So, in the mind of investigators, biobanking is still considered as a research tool. And it's also true for pharmas. And they want biobanking, and they want specific biobankings for the patients who are interested with, and to see what are the genetic differences between responder patients who respond to a drug, and patients who do not respond, trying to understand the mechanism. I think this is becoming much more important than that. Pharmas at the moment are developing what they call companion diagnostic, which is one test, usually rather simple, which is saying yes or no, you have a chance to respond to this individual drug. But how many companion diagnostic a hospital laboratory will be able to perform? 5, 10, 100, it will become a real bottleneck, a waste of time, a waste of money, a waste of competence, and a waste of material, because we will not have enough tumor material to do all these tests, to use only one drug. And all this kind of approach will be swept in the next few years, if not the next few months, by the next generation genome sequencing, which is really changing completely the way medicine will be done in the future, not only oncology, but also a number of other specialties. And it's it's stupid to speak of next generation sequencing because it's already there. Sure. It's actual generation sequencing. Prices are supposed to be enormous, and it's a limitation for that. But we are speaking of prices of drugs. Costs of biotechnology will obviously decrease, and decrease enormously because of competition, because of expansion of the market, and because now the new generation material is allowing to test thousands of samples in a few hours. So this change of scale will change the market, and it will be something like mobile phone or microcomputer. It will be really a new change in medicine. And I think our duty is to preempt that and to have our institutes and our healthcare organization able to handle with this new progress. And so I really believe that access to complete genome sequencing is becoming a request and a chance for every individual patient. And this means access to fresh tumor materials, kept frozen in biobanks. At the moment, some institutes are doing biobanking, more or less, some are not, and there is no global policy for that. It should be considered as a right for the patient to have material frozen and kept somewhere, even for the patient who will benefit now from a treatment. What will happen when they relapse in 2, 3, 5 years from now, when new drugs, new diagnostic tests will be available? If they have some materials, they have a chance to benefit of a completely new treatment, and they should ask for that, and they should require that. And there will be trial in courts of people who will claim that they have a loss of chances, of individual chances, because their material was not kept, was not frozen, and the proper genetic tests could not be done on their own tumors. And this will change the way of thinking of journalists, of politicians, and of farmers. And I really believe that this should be organized not in 10 years, not in 20 years, but now, because it's becoming a problem for the next few years, not to treat the patient tomorrow with a new drug, but to treat it in 2 years or 3 years or 5 years, according to the genome sequence of his own tumor now. And it should be asked and requested by the patient. And my idea is that it should become mandatory. Probably not to freeze tumor material at initial surgery or initial biopsy would become malpractice. Yep. And biobanking should become more or less mandatory. But it cannot be led to small individual labs. It should be provided at the national or the regional level with large, well-equipped, and with a competent personal platforms, with SOP, and all the quality control necessary to use this material for the benefit of the patients.
So biobanking should be, in your view, opt-out rather than opt-in. So the norm should become that your tissue automatically goes for pathology, but it also goes for banking and for whole genome sequencing. And from the pattern that emerges from that, you choose your drug. You don't go to the drug company and go and find patients who will suit the pharma companies.
And you choose not your drug, but your drug combinations, correct. Your own à la carte. I'm a French gastronomist. À la carte menu. And I really believe that it's the future for cancer treatments. It's probably also the future for a number of neurological disease and so on.
Thomas, thank you.
Thank you.
A brilliant expose of the future. It's not all pessimistic. There's a lot of optimism in your talk. Thank you very much.
I hope very much there is a lot of realism as well.
Thank you very much.